Hi, and welcome to another edition of Ask the Orthopedic Doctor here at Waterbury Health. My name is Jeremy Rodrigo. I'm the Director of Business Development here at Waterbury Health. And today I'm extremely happy to have with me Dr. Robert Hendrikson.
Pleasure to be here.
And Dr. Hendrikson is also known as the legend.
Something my office staff gave me a couple of years
Well,
ago.
you are legendary because you've been at it for a long time, right? You've been in the area a long time. So how long have you practiced in the area?
I would say I've been here about 40 years. And I began actually as a resident when I was at Yale. I came up and did my clerkship with Dr. Christophs Kegi in hip surgery back in 1981. And after that, after I finished my residency, I went to New York City where I did a hand fellowship. And at that time, Dr. Kegi called me and said, why don't you come back up to Waterbury and practice? And I gave it a lot of thought. I was a little undecided at the time. I had medical licensure in California, Florida, New Jersey, New York, so I was looking all over the country for an opportunity to practice my craft. And the only way I could come up with a decision is I made a list of parameters that I would consider, maybe 12, 13, 14 parameters, such as proximity to the ocean, which I really enjoy, cultural events, sporting events, schools, the surrounding environment. And every time I listed those categories, Waterbury came up number one in terms of professional opportunity. So I decided to go with Waterbury. I already knew some of the people here, and I think I made the right decision. Initially, I gave myself 5 years. I figured that I would know within that period of time if I was going to stay or not. And after 5 years, I know I made the right decision. In fact, the first day I arrived, Dr. Kegi had already scheduled 25 patients for me to see. And Dr. Beaumont, Charlie Beaumont, was on call, and he got a difficult trauma with a femur fracture and a ulnar nerve laceration. So he said to me, do you want the case? And I said, sure. So I was doing complex surgery already my first year that I would take 5 years to do in a setting like New York City or Los Angeles or San Francisco.
So the opportunities just presented themselves here in Waterbury, and you stayed here because became home for you, right?
Absolutely, absolutely. I was actually the first fellowship-trained hand surgeon to come to Waterbury, so there was a void at that time for hand surgery and microsurgery. I did the first replant of digital replants here in Waterbury in 1983. Actually the first and only hand transplant from an industrial accident. And so I really enjoyed my work, and it was very challenging, and it continues to be challenging.
So what's your favorite aspect of the specialty? You kind of concentrate on the hands.
Well, overall, I decided early on, I think in my training at Yale, as an undergraduate, I was mentored by each of the colleges had different mentors, and there was a mentor, Wayne Southwick, who was chief of orthopedics at the Yale Medical School. And so he became my mentor, and I really thought that this is what I wanted to do. I had been active already from an early age using knives and sharp implements. Even at the age of 3, I remember at a seaside resort, my first encounter, I was enthralled with someone who was whittling wood on a sidewalk. He was just sitting in a chair and whittling, making an object, and he let me whittle. Of course, he held my hands over the knife and guided me, and that was my first experience with a knife or a scalpel. Eventually, they became scalpels. So I went on from there. In the Boy Scouts, I was dealing with sharp implements all the time, And even at the age of 10, I was had an X-Acto knife set where I was using sharp instruments to create car models and airplane models, painting them and showing them, and so on and so forth.
So now at what point you knew that you liked to do things with your hands and create and cut and right?
Absolutely.
So when did you know you wanted to be a doctor?
Well, I thought early on, even before college, we had, when people got to college, we had one man in my entryway, one student, he said, I knew I wanted to be a lawyer from day one. Now, I kept my options open. I didn't realize I wanted to be a doctor until maybe my second year of college, and I really focused on the sciences, et cetera, et cetera. But I had a natural inclination for, I think, patient care, and that kind of ran in my family. My mother was a school teacher, and we were always involved with charity work and so on and so forth. So that kind of worked hand in hand with the craft of being a carpenter, doing orthopedic surgery with precise motions and precise decisions, and also taking care of people.
So like public service and helping and doing for others.
Absolutely.
Kind of ran in your family, kind of ingrained in the DNA of the family.
Yes.
So we're going to talk. I want to talk a little bit about wrist pain and fractures to the distal radius. What are some common causes that you see in your office of people who have wrist pain or ailments to the wrist? What are some of those common causes, and what do you do about them?
Well, you can break them down into primarily there's a tendonitis, which is an inflammation of a tendon. It can be chronic or it can be acute. There's multiple tendons on the top of the wrist and also on the volar or bottom of the wrist. So those tendons travel through discrete tunnels, and if they get inflamed, they can cause severe pain. So one common tendinopathy, as we call them, is de Quervain's tendonitis, which is an inflammation of the tendons on top of the wrist where they travel through a discrete tunnel. So those can be, by and large, most of the tendonitis conditions can be treated with rest, immobilization. I prefer heat. Sometimes if it's acute, we'll use ice. I have a lot of help, and I respect the occupational therapist and the physical therapist that work with me. So they are my main go-to in terms of getting the patient to a proper facility for their care, for the occupational therapy, for treatment of tendonitis, for example. I've had over the years my own therapy department. We've had, I would say, over 50 physical and hand therapists in our time. Some of them we've trained to become certified hand therapists. And under my tutelage, I've had probably 5 or 6 of those that became certified. So the therapy aspect of it is extremely important. Other conditions of the wrist are arthritis. Usually we see that in the older age group. Those can also be treated with rest and immobilization, or if that doesn't work, we'll use injections of cortisone. Now, the arthritic conditions, depending on how severe and where they are and what they are, we can also treat surgically very effectively. Another common condition of wrist pain or condition of that I see quite a bit is a so-called ganglion, or it's usually a swelling. It can be on top of the wrist or on the volar aspect of the wrist, and those we treat surgically. So I would basically say that most of the conditions that we treat around the wrist can be treated without surgery. but we do have that option of surgery to ultimately take care of the problem if the other avenues do not work.
So you don't necessarily walk into Dr. Hendrikson's office and expect to go into surgery. You have 40 years of experience, so you're going to say, well, I think we can do this with physical and occupational therapy. We rest it, we put it in some type of immobilization perhaps, and see how it goes. And if it progresses to a point where that's not working or that's not as effective as we like, surgery may be an option, right?
I would say 90% of the time that's the case. Now, I can say there are times when people walk into the office where they're unable to move a finger or their wrist, and that's typically a problem resulting from a rupture of a tendon. If that's the case, then surgery is your immediate option, which we like to perform as soon as possible to get the best results. I saw a patient just yesterday who had a laceration to his finger 2 weeks ago, and he was unable to move his pinky finger. And on exam, I diagnosed a laceration of the tendon. So he's scheduled for surgery the day after tomorrow to get that fixed.
And ideally, he would have come in within a day or two of or as quickly as possible after the injury had occurred instead of waiting a couple weeks.
Absolutely, yes.
Yeah. When you are taking care of a patient with wrist, hand, things like that, what can they expect when they come into your office? And I'll tell you my story because I was in your office yesterday, but they don't necessarily have to be referred by their doctor, but they could be.
Yes,
their primary
that's correct.
care. But they could just go to you if you have something that's bothering you with your hand or your wrist, and you say, I think I should go see Dr. Hendrikson. I saw him on Facebook Live. I think I'm going to go see him. What can they expect when they walk through the door? They make an appointment, of course, and then they walk through the door.
So I tell my receptionists that they are the most important person in the office because they are the person that the patient encounters initially, either by phone or when they come in. And a lot of times patients will wait months and months. They're just afraid to come to the doctor. So if the receptionist is not kind or not helpful or not compassionate, they may turn away and not come back. So I basically, now I have a great office staff. It took 40 years to get there. We've had probably over 200 personnel in my time in the office, and we got a great core of staff members at this time. So they'll first see the receptionist, and then they'll come in and they'll come into the exam room. And depending on what the problem is, they might have radiographs taken before they even see me, which helps basically with the flow of the office.
So I'll tell you my personal experience with your office. I called them on the phone. The receptionist was amazing because I didn't know what to expect. I'd never broken anything or even had an injury that I thought needed an orthopedic surgeon or physician to talk about. But I called the office and I explained what had happened. She was wonderful. She scheduled me very promptly. I arrived at the office, very small amount of paperwork to do, took my insurance cards and things like that. Someone greeted me, brought me into the exam room. I got x-rays. It was just like very clockwork, right? And everyone was super supportive and nice, right? Your x-ray tech took the x-ray. She was great. And then I saw Dr. Patel, who works in your office with you, but your office is like on point, and I work in healthcare, and I should be more comfortable. But when you're talking about your own hand, your own injury or whatever, you don't necessarily know what to expect. But it was great. I'll tell you what, I was super impressed with your office and the way that they did, the patient intake, and everyone in the waiting room seemed to be very happy and very modern office, very clean, modern. It was great.
Well, thank you. Like I said, it took 40 years to get there, and it's a constantly evolving process. And I have a saying, as far as surgery goes, you're only as good as your last case, your last surgery, or your last patient. So I think I try to advocate that to my office staff, that they need to take every patient individually and treat them as best they can.
And so, which brings me to my next point, which is you've been practicing for 40 years, and what you learned 40 years ago may not always still apply, right? Like, medicine is changing, techniques are changing, and although you were trained way back then, you stay up to date with all the latest technologies and techniques and all the things that are being taught, right?
Absolutely. There's been a sea change in orthopedic care in my time. I can give you two examples. One is the treatment of wrist fractures, for instance. For the operative treatment of wrist fractures, we've gone through a myriad of techniques, certain types of appliances to help heal the wrist after surgery. And now we've gotten to the point where we use a plate generally on the volar aspect of the wrist, either for fractures that are in the joint or out of the joint. And that plating system has evolved even on its own through, now we're into the fourth or fifth generation of that plate. And that's something we did not have even 20 years ago. Another example is vacuum dressings, which was developed in Virginia by a scientist. He started with pigs, and it took him years and years to develop the system where you could take an open wound, which in the past we would have to do a free flap or some type of other flap to cover that area. And now we can use a vacuum dressing where the dressing actually sucks out the fluids and allows the body to heal itself in a prompt manner without additional surgery. So having said that, we still have those other procedures available to us. And if worst comes to worst, we can always still do a free flap, right, or a rotational flap. During my training as a hand fellow, I worked with a plastic surgeon for 6 months. So I use those plastic surgical techniques throughout my practice, which probably over the 40 years, I would say I've had over 40,000 procedures that I can hang my hat on.
I was just going to ask you how many procedures you've done in a 40-year career. You're thinking about 40,000 procedures.
40,000.
Isn't that something? That is something. You can't ask for much more experience than that. You want an experienced guy, you go to the legend, right? I wanted to talk a little bit about, earlier we said we would touch on radius fractures. So where is the radius, and what is a radial fracture, and how would you take care of something like that?
So the radius, there's two bones in the forearm that start at the elbow and end at your wrist, articulating with the hand. There's the radius, which is the larger bone, and the ulna. So the two bones allow flexion, extension, and radial deviation and ulnar deviation, and also pronation, supination. So they work as a unit. And the fracture of the distal radius is a very common injury. It's right through the distal part of the radius. Typically, the most common fracture is extra-articular. In other words, it does not involve the joint. And by and large, most of those can be treated if they're in good position just with a cast or a splint. If they're displaced, we can do a closed reduction and then treat them again with a cast or a splint for a period of 6 to 8 weeks to healing. If, on the other hand, if they're not reduced anatomically, then we have that surgical option for us.
Now, what are some of the common causes? You say it's a very common injury. What are the common? Is it falls? Is it a certain age group?
Well, the falling is probably the most common. We call it the falling on your outstretched upper extremity.
Yeah.
And if someone trips, they can fall. If they're running, they can fall. Oddly, if let's say they're swimming and slam into the side of a pool, that could cause a fracture of the distal radius as well. But the falls are the most common. And I would say, as far as age group, as we age, typically the bones become a little more osteopenic. In other words, a 70-year-old is not going to have the same bone density as a 20-year-old. And if a 70-year-old falls, they might be more prone to fracturing the wrist as opposed to a 20-year-old.
Right. And to touch on that, those falls and the injuries that occur, you still are on call for trauma.
Correct.
Right?
Yes.
Waterbury Hospital is a trauma center, so you may be brought in here by ambulance if you were involved in a fall or a car accident or something like that. And if it's your hand, you may see Dr. Hendrikson. You may not see him that day, right? Sometimes you don't necessarily have to come in that day.
Well, we have a great complement of physician assistants that work with us, and I have to say, they are so skilled, I would put them in a category of orthopedic surgeons. And that, again, has evolved over the years with our training. The days when I started, there were times where I was taking call every other night. And for hand call, I was taking call every day. That was for the first 3 to 4 years of my practice. So we would start on a Friday evening. You might work. I was on call Friday, Saturday, Sunday. You might work until 11 p.m., come home, sleep. You'd be at the hospital by 5 or 6 in the morning, and you'd stay there until, again, 11 o'clock on Saturday, and repeat everything on Sunday until Monday morning. Now, with our physician assistants, they will call us if there's a fracture in the emergency room, and with our technological skills using and our smartphones, etc., we can actually look at X-rays on a computer or on a phone and determine if we need to come in to either help with the reduction or go ahead with surgery. So life has changed for the better in those 40 years in terms of being on call.
I was thinking that sounds exhausting, to be on call and then leave it at 11 o'clock at night and come back at 5 in the morning and do it over and over and over again.
It does take its toll, and I can say it's a young man's game, as it were, or a young woman's game. The replants that I've done, the minimum 8 hours of surgery, the longest was 16 hours, and to recover from that, really at the time, took about a week. Now it would probably take me about a month
to recover
if
from
I had
all
to
that.
Do that. Yes.
Yeah. Now, you talked about a replant. I think I know what it is, but what is that?
Replant is if a finger gets amputated and it's a clean amputation, it has to fit certain criteria. Typically, they have to be a healthy patient, under a certain age, and a particular digit even. And if it's a clean amputation, such as with a saw, then we can go ahead and reattach that finger completely, sewing the nerves, the arteries, the veins, the tendons, and then also fixing the bone that's been cut. So we don't see that many of those anymore.
Yeah.
I think part of the reason is because OSHA has evolved with certain care and safety procedures in the factories. So we're not seeing the level of accidents that we've seen in the past.
And that's a good thing, right? I mean,
that's a good thing. I
worked on an ambulance for 30 years part time, and I've picked up my share of digits, and sometimes they can be reattached and sometimes they can't, but we always bring them in and let you do the best that you can. So I wanted to talk to you about, if you have a chance, if you have the inclination to talk about the New York Yankees.
Okay.
Right. So tell me about the Yankees, because you shared this with me last time we met. Tell me about your interaction with the Yankees.
Well, I do have a plaque in my office
Okay.
that refers to the Yankees. But when I was doing my fellowship, I worked with a doctor who was team physician for the New York Yankees, as well as the Islanders, the hockey team on Long Island. So we would cover the games, and we would do surgery on, I remember clearly, Dennis Potvin, he was with the Islanders. Then we had Rick Cerrone, the catcher for the New York Yankees. Craig Nettles played third base. Goose Gossage.
It's a legendary Yankee team.
Absolutely. So they all underwent surgery, and I can tell you that they are phenomenal. The professional athletes, in terms of not only their abilities to play sports, but just I like to say their protoplasm, what they're made of. They're just unique individuals. They heal faster than you or I would heal.
Yeah.
And they're back playing generally much earlier than the normal amateur would be playing.
So the same doctor that took care of Goose Gossage could take care of you, right? The legend.
Absolutely.
Yeah. It seems to me that the hockey players would have an awful lot of injuries.
Well, they do. The hockey players, because it's contact constantly.
Yeah.
And the ironic thing is, when I was at Yale, I announced as an undergrad, I announced the hockey games for Yale, and then when I was a resident, we covered not only the hockey games but also Yale football. So I was in the back room sewing up hockey players after lacerations, et cetera, et cetera. So yes, the hockey players have a lot more contact, and even with their face guards and everything else, they still end up with lacerations.
And you were sewing them up in the back, and
absolutely, yes.
And they probably went right back on the ice. I do have a question from the audience. How did Jeremy break his hand? Jeremy broke his hand shoveling dirt. I was shoveling dirt, and the end of the shovel is like this, and I was shoveling, and fluke, bent it way back, fractured. What did I fracture?
Fourth metacarpal.
Fourth metacarpal fractured. Got to keep this on for 6 weeks.
Just to embellish a little bit, you showed me your X-ray.
Yes.
And that's called a spiral oblique fracture. And typically those can be unstable, so the finger can rotate. So these are all little nuances that when the orthopedic surgeon examines the patient, they can already see across the room. If I see someone who comes in with that fracture and the finger is a little rotated, I know that this could be a problematic fracture. Yeah. So those very often can end up having surgery. In fact, I'm currently treating a woman who is the wife of a state representative here, and she had similar fracture, and her finger was rotated, so we ended up fixing it surgically.
Surgically.
Yes.
And from what Dr. Patel tells me, the hope is that if this brace remains on, and I'm diligent about keeping it on, it should heal itself. But, if it doesn't, surgery is an option.
That's correct.
Yeah.
I would say 95% looking at your X-ray, it's going to heal up fine.
I love that. All right. Thank you, Dr. Hendrikson. Thank you. That was really interesting. I really appreciate you taking the time and being with us today. This was Facebook Live Ask the Orthopedic Doctor. I'm Jeremy Rodrigo. Thanks for tuning in. We'll catch you next time on May 31st. We're going to have Dr. Michelle Mariani, And she is going to talk about other orthopedic stuff because I can't read what it says. But we're going to have Dr. Mariani on the 31st. Thanks again for tuning in.
Thank you, everybody.